Hello, I'm Congressman Jackson, representing Illinois' 1st Congressional District. I have an amazing opportunity today. I was graced with the opportunity once again to have a visit from my county board president, the County of Cook County in the state of Illinois. With us today is County Board President, Madam Toni Preckwinkle. Great to see you today.
Thank you. Thank you for having us.
Thank you. Let me ask you, what brings you to Washington, D.C. today?
Well, as you may be aware, Congressman, and we're very grateful that you enabled us to be with you, we come every September to talk to our congressional delegation about our healthcare system. Now, we often bring up other topics, but mostly it's about healthcare. I have a $9.9 billion budget in the county.
How much is that?
$9.9 billion, almost $10 billion. $5.9 billion of it is healthcare. So this is a big deal for us, the health and hospital system. We have 2 hospitals. We have a dozen outpatient clinics. We have a Medicaid managed care program called County Care. And together, as I said, that's 60% of our budget. And I'm very proud of the work that we do. For 180 years, we've taken whoever comes to our door, regardless of their ethnic group, their race, their gender, whether or not they have insurance, whether or not they are documented or undocumented. And this has been a blessing for a succession of people in Cook County, starting with German immigrants, and then, of course, Italian and Irish, and now more recently people from Central and South America, from Mexico. It has been a godsend for the people of Cook County.
May I ask you a point of clarification? When you say you take everyone, is that uninsured and uninsured?
That's right. Anyone who comes to our door will get care.
Wow, from around the world for 180 years.
For 180 years.
Can you give me an idea about the size of the county relationship to other counties? Where does Cook County fit in as far as size?
Sure. We're the 3rd largest city in the country after New York and Los Angeles, the 2nd largest county. Los Angeles County is the largest. Every borough in New York, all 5 boroughs are counties. So Cook County is the 2nd largest county in the country.
Wow, that's phenomenal.
5.2 million people.
And you have to administer the health. So the city of Chicago does not administer its health system. The county administers the health for the city of Chicago and surrounding communities.
It has a public health system, but we have the hospitals. The public hospitals are county, both Stroger Hospital and Provident Hospital. And as I said, we also have a dozen clinics around the county where we serve folks.
Can you tell me some of the services that you provide within the county hospital?
Everything, but let me introduce, my compatriot here. This is Dr. Erik Mikaitis. He is the CEO of our health and hospital system, and we're joined by Commissioner Bill Lowry, who's chair of our health committee, and vice chair, Commissioner Anaya.
Well, if I can turn this towards Dr. Mikaitis for a question, there's HR1. What do we need to know in the state of Illinois about HR1?
So a few key pieces, but I want to start by setting the baseline using Cook County Health as an example. In fiscal year of 2024, 56% of our revenue was generated through Medicaid covered patients. $828 million is what that equated to. At the same time, we provided $230 million in uncompensated care and charity care. This year, that's increased to $280 million. And preparing for next year, we're anticipating $380 million in charity care. A lot of that is in anticipation for what HR1 is going to do. We've seen some local state level programs that have changed or been eliminated. We've also seen the start of what's called redetermination. That is when patients who are covered by Medicaid have to, right now, once a year, submit paperwork to show that they're still eligible to be on Medicaid. So HR1, now the most immediate concern that we have is a program called DSH, or Disproportionate Share Hospitals. What that does is try to offset hospitals and health systems that have very high levels of charity care, high levels of Medicaid. And for us, DSH, well, for the country, DSH program is set to expire as of October 1st, so the end of this month. If those DSH cuts aren't delayed, for us, at a minimum, it's going to equate to at least $120 million hit to our bottom line. So that's one of the first things that HR1 is proposing to do. There's 2 more pieces in terms of Medicaid coverage that we're very concerned about. They've proposed implementing work requirements at the beginning of 2027, which will require people with Medicaid to submit proof that they are working or volunteering in order to stay on the Medicaid rolls. And also, I mentioned the redetermination. That's right now done once a year. What this bill will do is make that happen twice a year, so it's double the amount of paperwork for anybody covered with Medicaid. Those financial impacts for us, I kind of ran through the numbers just a bit ago. So we talked about $120 million for DSH, the Disproportionate Share Hospital Program. Work requirements, we're anticipating an $88 million impact to our bottom line, and work requirements would be $88 million impact to our bottom line, and the increased cadence of redetermination
Okay,
would be
so
$50
let me
million.
ask you a question. So for some people, because people get real sleepy talking about
Yeah, the big
healthcare
numbers, right?
until they need the health care. So things are changing in our health system. So what was available last year that's changed this year as a result of HR1?
So HR1 hasn't really come into play yet. What it's going to do, bottom line, people are going to lose coverage. The work requirements, this increased cadence of submitting paperwork, people will lose coverage. And what that's going to end up causing is chronic disease being unmanaged. People will tend to not engage with their healthcare providers. It's going to lead to more acute issues where instead of treating high blood pressure and diabetes, we're going to be treating strokes and heart attacks.
Okay, and so when did HR come into effect?
So it was approved just a few months ago. And those two pieces about Medicaid will come into play at the beginning of 2027. And the DSH cuts, as I said, will go into effect, unless there's a delay, will go into effect at the end of this month.
So what is Medicaid called? It has many names, and so it's under one big umbrella. So I find some people don't know that they're on Medicaid.
Yeah.
What is Medicaid called in the state of Illinois, for example? And it changes state to state.
It does, and that's what makes it confusing, right? There's Medi-Cal in California, right? Illinois is just Medicaid. There's multiple managed care programs. So for us, we administer county care. So that's our products with Cook County Health. It's the largest managed Medicaid program in the county. We have the most patients in the county under the plan. The state, though, it's known as Medicaid.
So some people think that that Medicaid does not affect them because we have Cook County Care, but that is Medicaid by another name?
Correct. It's the administrative product that is delivering the Medicaid coverage.
So what was your first reaction when you heard about this bill being passed in Washington, D.C.? Where were you? How do you remember the bill coming to being?
Well, there was a lot of movement, and there was a lot of kind of changes as the bill moved through the various stages of approval. We were hopeful initially that the bill that passed the House, that the Senate would have had a more humane approach on. Unfortunately, it was actually less humane. The timelines were accelerated for implementing a lot of these pieces of the program. So as you can imagine, that caused a lot of concern in terms of what this will mean for patient outcomes.
So unless we turn this bill around and take back the House, in like 14 months from now, when we look past 26, which is 4 months away, and then on to 27, we're going to see persons that can potentially lose their job, that are looking for their high blood pressure medication. Will that resource still be available in the county?
So, as Madam President said, they can always come to Cook County Health. We accept everybody regardless of ability to pay. The challenge will be, what pressures will that put on our health system? There's a broader healthcare safety net ecosystem that is already at risk right now. We talked a little bit about state level programs. We've talked a little bit about the current re-enrollment that has started already. So we're already seeing people losing their coverage because that process has restarted. That alone has already started to cause a lot of destabilization in that ecosystem.
So people are losing their coverage because of what? What's the factor?
So it's redetermination. So during COVID, there was a pause on redetermination. So anybody who had Medicaid coverage didn't have to submit that paperwork. They just maintained their coverage. When the public health emergency ended, redetermination started again. So it required people to start submitting that paperwork to maintain their Medicaid coverage.
And redetermination just means proving up your eligibility for the program. It's healthcare speak,
Right.
but it just means you got to prove up that you're eligible. And instead of doing it once a year, they're now going to make people do it twice a year. And of course, people move. People get caught up in their lives and maybe don't respond, submit the proper documentation, and as a result lose coverage for which they're eligible.
So you might have lost your house, you stay with your family, your mail was still going to your current address, you might have gotten evicted, you might have sold, the mail didn't forward you, you might have missed the opportunity to get notification to...
Timely, yeah, and then you lose your coverage.
For the year or for the rest of the year, for the next 6 months?
So when you re-engage with the health system, you can, or with any health system, you can reapply if you still qualify.
And so, what has been the effect of this nationwide? What have we seen in other cities, other counties, other states when this program went into effect?
It's loss of coverage. I mean, that's fewer people have Medicaid coverage, and the downstream effect of that is like we said, people don't engage in that preventative care. We know that as a fact. When you don't have coverage, you tend to not, see your doctors, take care of yourself, take care of those chronic diseases, and that inevitably leads to higher acuity. You end up sicker, and as a healthcare system, that becomes much more expensive, not just financially, but from a community and an individual standpoint. It's much worse to have to deal with somebody with a stroke instead of having them take their blood pressure medicine.
So I have two more questions for you on this here. One of which is on the able-bodied without children.
Mm-hmm.
What does that mean for people that are seeking Medicaid coverage?
So they'll be the ones most impacted. The HR1 is really the work requirements and the redeterminations for everybody. The work requirements, that's really targeting that population. It's the patients, the members without children who are able-bodied that have to prove that they're actually working.
So for a single mother or a single father, single parent household, you've got a child that's 13 years of age, 14 years of age, and now they're saying you have to do more work or volunteer. What's the new rule?
Yeah, I believe it's 40 hours a month of volunteer.
Which means
Or
you have
work.
to go and online apply to show that you've tried to volunteer?
So that's the behind piece, and it's actually 80 hours. Let me correct
Okay.
myself. It's 80 hours a month of either part-time work or volunteering. And the back end of that, I'm not entirely sure that all the states have quite figured out how they're going to track that. It's incredibly onerous. We've seen programs like this tried, right? For example, Arkansas tried this. They had 18,000 people lose coverage in the first 4 months. When they looked back, a federal judge had to stop the program, by the way. And when they looked back at those 18,000 people, 97% of them should have maintained their coverage. It was just a matter of doing the paperwork, submitting it the right way, or they were exempt, and that wasn't recognized. Most of those people should have maintained their coverage.
One last question for you on this. So when you say people that have the coverage and they have to what's that fancy word you use?
It's called redetermination is the
Reapply.
process. They have to reapply. Yeah.
Okay, just to stay qualified. Okay, I got it now. And so what's going to happen now for a senior citizen that may not have internet, that has a phone that they're not computer literate? Like, how does that person maintain their eligibility? Is there a center that they can go to in the county, or is this all online?
Not a dedicated center right now, but if they come to Cook County Health, we help them kind of through that process. So we would be a hub that would allow them to have that assistance to maintain their coverage. There is not a really coordinated place right now. Again, I mentioned Arkansas and that administrative burden on the state to administer that program so that they can monitor the work requirement program. It costs them $24 million just to put that program in place, to administer the program. So I mean, there's that burden that's just to shuffle the paperwork, right?
So senior citizens are going to have to do more paperwork.
Anyone covered by Medicaid who would be impacted by either the redetermination or the work requirements is going to have more paperwork to do.
And let me just say, most of our seniors are eligible for Medicare, but some are dual eligible people. They're eligible for both Medicaid and Medicare, and those are mainly people in our nursing homes. So this is going to be a real challenge to families who have looked to nursing home facilities to care for their elderly and disabled family members.
Well, more people are going to be coming off. Dr. Lowry, Commissioner Lowry, always great to see you.
Always great
coming
to see
out.
you, Congressman.
How is the implementation, the access to this HR1 going to impact our county?
Well, let me first say, I want to shine a light on you and your not only impactful, but your generational work. Everything you do, everything you bring back to the district and beyond, it's based on today, but also tomorrow. So thank you. You're exactly the leader we need, and we really appreciate you. So I'm going to start with that. At the outset, President Preckwinkle mentioned, in addition to serving as Cook County Commissioner of the 3rd District, I also chair the Health and Hospitals Committee of the Board of Commissioners, and I serve as Vice Chair of the Cook County Health Board of Directors. So I've been very fortunate to work very closely, not only with the President and my colleagues, but with Dr. Mikaitis. And I also want to say thank you for your leadership with this. But in doing so, it's very clear to me, health care is a right shared by us all. It is not a reserved privilege for the few. So you start with that. And even with that truism identified, the fact is we have communities in Chicago and throughout Cook County which have experienced healthcare inequity for decades and decades, as well as lack of accessibility. The actions of this administration are only going to exacerbate that problem in those communities. And as we look at these actions, let's call it what it is. This administration is dehumanizing individuals across this country. And we talk often about the effect of what's happening with this administration in our districts and in the city of Chicago. But it's going to have impact relative to the red states. It's going to have impact relative to the red counties. And I think as we prepare to fight this, that's what we have to focus on. This is going to affect all folks. And at the end of the day, that's the first thing we have to do. And we have to create the message. But that starts with us putting together and really compiling the data so we can make that message. And we need to know the actual impact of this initiative on numbers, because that's how we're going to be able to make the case that this has to be changed. And as we go through that, we've got to talk to folks. We've got to, while individuals are being dehumanized, we've got to put a human face on what's happening. And in addition to the data, we've got to collect stories. And I'm going to give you an example. So every September, in recognition of Prostate Cancer Awareness Month, I have the Commissioner Bill Lowry Men's Health Fair. And a year ago, I was talking about the health fair, which was coming up in a couple of days, and I was on the radio show of someone you may know by the name of Santita Jackson. And while we were talking about this very important health fair, but also just prostate cancer and the fact that no man should die from prostate cancer, but in order to live those words, you have to know what's going on in your body, you have to take the steps, and we detailed the steps. We received a call from a man. I could use his name, but I'm not. And he said that he had just lost his job. And he lost his job after it was determined that his PSA level, that's the prostate specific antigen test, you want that to be 4 or below, was 16. As a result of that high reading, he then had a MRI of his pelvic area, which showed inflammation. Might mean cancer, might not mean cancer. He was scheduled for a biopsy to determine if, in fact, he had prostate cancer, and he lost his job. And Congressman, you could hear him on the phone, his voice broke. He says, I don't have a job. I've lost my insurance. What do I do? And by the end of that day, we had him at Providence Hospital, one of the gyms of my district. And we started the treatment even though he did not have a job and he did not have insurance. He called me March of this year. He's cancer-free. It's individuals like him which require us to fight back and push back. And in my own story, I was elected for the first time in 2018. Since 2018, I've been diagnosed with cancer twice. I'm able to sit here and talk to you today, cancer-free, because I had access to health care, which allowed me to have early detection, which allowed me to do what I needed to do to be cancer-free. That's what's at stake here. That's what we must do. Now, we at Cook County, I'm very proud of this, January of this year, we started a cancer screening program. So now women in Cook County, 40 and above, can get a free mammogram, whether they have insurance or not, at any Cook County hospital or clinic. Men 45 and older can get a free prostate screening at any Cook County hospital or clinic, whether they have insurance or not. And we use that program, and I then passed a resolution at NACO, the National Association of Counties, right here in Washington, D.C., and I added lung screening. So we're now making an effort to get counties throughout this country to have similar screening programs. Such programs will breed early detection, overall wellness, but they'll also extend lives, life expectancy. Efforts like we're seeing from this administration will only frustrate the ability of counties to have such programs. So that's another reason why we must get the message right, which has to be based on people and human beings. And when we're prepared to do that, I think we're going to find on both sides of the aisle we can fight this.
Well, I thank you for that. Our jurisdictions overlap in your district and Anaya's district. The 1st District of Illinois has the highest number of Medicaid recipients
Right.
in the state for a congressional district. So that's 1 in 4 persons in the 1st Congressional District. We have a high number of safety net hospitals that were already vulnerable.
Right.
Many lacking maternity wards and other good things. And so, Anaya, I want to ask you, and thank you for your work as an outstanding county commissioner, how will this impact the vulnerable communities, this HR1 bill?
Yeah, absolutely. I think, first of all, thank you so much for having us. But you alluded to something very important, which is our FQHCs and our support systems. We're very glad that as a system, we have joined forces historically to be a safety net, to be a place where people do access health care, where they get treatment. We strive to provide that treatment with dignity and respect, and we hope to continue to do that. But what we're seeing overall is the chilling effect of already even just the talks of HR1, even just the crunching of the numbers for our FQHCs who serve a lot of vulnerable populations, and what that will do in the long run. So we've already heard of many potentially closing. There's been hospitals in the region who have already signaled that they will be closing. And what that will cause is, number one, that delay of access, the delay of treatment for some of the things that we've just talked about, but overall, the situation regarding the influx and the devastation that it will be causing to some of the systems that are the safety nets. So if we stay standing firm to our mission of taking anyone, regardless of their ability to pay, regardless of whether they have insurance or not, regardless of their immigration status, we know that we're going to see many more individuals. But it won't be for preventative care. It's going to be for more crucial and devastating health outcomes like the ones that have been highlighted previously.
So let me ask you this here. So during the height of COVID, we reached a sane period where we realized that it was contagious. There were vulnerabilities everywhere, and we had to open the gates to let everyone in to stop this contagion. How does things change post-COVID? What funds have been removed, and what's different?
I mean, I think overall, we saw the importance of healthcare. We have always known it, right? We understand that healthcare access is a human right, that people should not lose their lose their lives literally by not having access. So I think what COVID also taught us is that we need to make sure that we continue to sustain the safety nets, that we continue to see and fund the vaccines, funding of the programs, of our public health system, and our general ecosystem in regards to how people really access it. So I think overall, although we have seen some, cuts based on, terminology for some of our things like, diversity and other aspects of healthcare, I think what we really want to make sure that we yell really loud is the fact that we are already in a situation where individuals feel like they can't come to our systems. We are already in a situation in which we're analyzing the impact of, if we do continue with HR1, what it will cost just in general, and the chilling effect that we will see. And to your point about vulnerable communities, I think it's important to highlight a lot of what we just mentioned. It's going to be our senior population. It is going to be our population with disabilities. It is going to be our immigrant population. And when we see that public health overall for certain individuals is not where it needs to be, everybody's going to suffer. And in turn, we all become vulnerable populations because we will not be able to have the access that we need.
But Congressman, there's another piece to it. So as a result of COVID, we received funding through the American Rescue Plan Act, and we received $1 billion. And I certainly will ask the president to speak to this, but one of the resources that we were able to provide led to medical debt relief for individuals, and this was key. But all those dollars had to be allocated by the end of last year and have to be utilized by the end of 26. So it makes it even more imperative for us to continue some of the initiatives and some of the resourcing that we started post-COVID, we need those federal dollars.
So when we talk about what's going to happen with Medicaid cuts in the state of Illinois, how much funding from the federal government is going to leave the state of Illinois?
I think that's unclear right now. In the state of Illinois, we're one of 12 states that have trigger language in our state legislation. Right now, it's a 90%, 10% match, where the federal government provides 90 cents of every dollar that's spent for Medicaid. The state provides 10 cents. If that falls below 90%, the state of Illinois has language right now that would cause us to have to roll back the ACA expansion, Obamacare. They'd have to take away coverage for all of those people, and it would, for our county care coverage, would be about a quarter of the people who, about 100,000 people in county care would lose their coverage. But if I could come back to COVID from a medical standpoint, what we saw, I think it highlighted the discrepancies in terms of access and outcomes when COVID hit, and the funding that, you asked about kind of funding and grants. What we saw at the end of the public health emergency, our public health department for the county of Cook actually had several $1 million pulled back. We were using that for vaccine awareness, for disease monitoring, trends in the communities. So that was, obviously challenging. We more recently were involved in a program that was focused on driving quality outcomes and blood pressure control on the west side of Chicago in an underserved community. It was a partnership with several of the local healthcare centers, and we found out just a few weeks ago that because it had some relation to the word equity, that they pulled the funding back for that program.
Well, you've really touched on a very sore spot for me on the term equity and the term diversity and the term inclusiveness and the term accessibility and the term disparity, that people don't quite realize how those terms have hit the medical profession, that there are studies that were going on to deal with cardiovascular that were disproportionately hitting the African American community. There was Black maternal health, there was Hispanic health initiatives that all of our agencies across the entire nation have had to put on the side because the federal government is now attacking not just the law firms, not just the medical institutions, not just the universities. They're attacking everything that has that word. How important is it that we look at specific communities that have specific pathologies that we have to address? How is that altering how we treat people and illnesses?
It's extremely important. I mean, that's what drives outcomes is how we engage, the access that we provide. When we see 20 to 30 year life expectancy differences between Englewood and Edgewater, an underserved community and a wealthier community in Chicago.
Well, you said that again. What's unique about Chicago and life expectancy?
So there was a study done that showed, I believe it was a 30-year life expectancy difference between Englewood, which is an underserved community, and Edgewater, which is a wealthier community, in life expectancy. So, it might be 60 versus 90 years old, right, between those two communities, and they're very close together.
And that's a structural deficit we have. Madam President, I'm going to ask you for closing comments and thoughts. You've been on this for so long. You've done so much. You know everything at the ward level, at the city level, at the county level, at the state level, and being in the second largest county in the United States. Now you get to see which way this is going to affect counties all across the country. What should we know about this HR1 bill and how it's going to affect counties? You're at the front end because you're dealing with the most patients.
Well, the National Association of Counties, NACO, has made Medicaid one of its priorities in its lobbying in Washington around the big, beautiful bill. The preservation of Medicaid is important, not just to large urban counties like ours, but to small rural ones. We're going to see closure of rural hospitals. We're going to see closure of rural federally qualified health centers, outpatient clinics. We're going to see closure of nursing homes, not just in Cook County, our large urban counties, but across the country. And in many of our rural areas, there's only one hospital within 100 miles. There's only one nursing home. So when these kinds of devastating closures take place, there's a terrible ripple effect in terms of access to health care across broad swaths of the country. And so we have to understand this is an issue for every county, red or blue, and we need to come to Washington, as we have, to talk to our legislators, as we've been coming to you, to ask for their help and support as we negotiate a continuing resolution to keep the government operating, and as we look toward the budget for 2026. I am grateful to you for giving us the opportunity to share this information with our constituents and hopefully encourage them to contact their legislators about this issue as well.
Well, I want to say to each and every one of you collectively and personally that I am proud to live in Cook County and proud that we have a county health system that have you all at the leadership, and that this has been open to all that are sick, that you've not seen ethnicity, you've not seen race, you've seen sickness and you've dealt with it, and you're on the forefront of creating solutions. So thank you for coming out. Thank you for your advocacy. This is a renewed focus for me in the 1st Congressional District. What's happened now with Medicaid, we have to sound the alarm and let everyone know that there are going to be more people sick. We've gone from the preventative now to trauma. He's traumatized our whole country. But you're doing a marvelous job, and I want to thank you, Anaya. I want to thank you, Bill. Thank you, Dr. Mikaitis. Thank you, Madam President.
Thank you.
And
Thank
continue
you, Congressman.
success.
Thank you.
Thank you.
This is Congressman Jonathan Jackson from the 1st Illinois District of Illinois. Have a great day.